Sorry, food coma. SAT and MAC scores. How does it affect outcomes? Thank you. These are my disclosures. Many of these slides are from a good friend, Roberto Ferraresi, who is the guy who brought SAT MAC to all of us. So what do we have for calcium? We've got intimal calcification, medial calcification. Let's look at medial calcification. Typically occurs in diabetic CKD, pretty much bone formation around the media of the artery, usually manifests as railroad track signs on the X-ray. And it's different. It increases arterial stiffness as compared to the intimal calcification. So this was initially described by Monkeberg, and it's just a deposition of calcium phosphate. How common is MAC? 17 to 42% of patients with diabetes, up to 40% of patients with advanced CKD, and up to 3/4 of patients with critical limb ischemia. Effects of MAC, we mentioned that in medial artery calcification, it does not necessarily lead to vessel occlusion, mainly reduces vessel compliance and potentially causes local ischemia as compared to plaque rupture you get with intimal calcification. Let's move on to the clinical. What do we have? What are we faced with? We've seen multiple cases here today of both transmission failure, but another problem that we're facing is distribution failure due to small artery disease. And when I say small artery disease, it's not the dorsalis pedis, it's everything south of the dorsalis pedis and the lateral plantar, and that leads to a no outflow scenario. How often do we get small artery disease? A typical picture in angiogram of a patient with a good distribution system, an impaired distribution system, and somebody who has a very poor outflow system. Is there a better way that we can identify a SAT disease? Yes, we can do this with a MAC score, and this is a score that was devised by Roberto a couple of years back. Pretty simple. Take an X-ray in the lateral and the AP foot, and then you can score them based on the length and the location of the calcification, and with that, you can decide if this is a patient with no MAC, moderate MAC, or severe MAC. And what he did is he looked at a bunch of patients in his practice and correlated that with an angiographic score, and found that there was a good correlation between the MAC and the SAC score, where the more calcium you get in the foot was indicative of a more small artery disease on angiogram. So does it affect cardiovascular outcomes? Medial artery calcification was investigated in a 10-year follow-up study of 130 patients with diabetes and was found to be correlative for cardiovascular mortality. So MAC can be considered a silent killer. So if it doesn't kill you, does it affect your limb? Again, data from Roberto Ferraresi's unit, SAT score was independently associated with critical limb ischemia. And I drew some lines here, if you have severe medial artery calcification or a high MAC score, at 6 months, the chance of complete wound healing is less than 20%. Let's think about this for a while. A patient with critical limb ischemia with calcium everywhere in the foot. At 6 months, less than 20% chance of complete wound healing. And at 12 months, it didn't improve a whole lot, not more than 30% of complete wound healing. And naturally, repeat surgical intervention or minor amputation or the salami effect was very prevalent in patients with high MAC scores, and freedom from recurrent interventional revascularization was high as well. So this is a meta-analysis of 15 studies with 6,000 patients. This is associated with all amputations, highly associated with major amputations as well as minor amputations. It's been validated in other studies. These are all the other studies that validated the MAC score. I think this is the latest over here. So in summary, MAC is often overlooked in daily practice. It is predominant calcium in the diabetic critical limb ischemia. New scoring systems can easily screen for SAT MAC using plain radiographs. It's predictive of an adverse outcome in the limb as well as the cardiovascular system. Potentially, if you have a high MAC score, would this patient be better served with alternate methods of revascularization? And in my opinion, instead of planning for the treatment by doing routine ultrasound to look for vein grafts, maybe we should be doing MAC scores to triage the patient with critical limb ischemia. And we always triage before we go to theater. Thanks.